All right, so I have a case for us to consider. It's going to cover a lot of different really high yield points. I think it's going to do a lot to kind of connect the pieces and integrate things here. I think it'll be well worth your time if you sit through, listen to everything I have to say, and also pause your screen when I ask questions and try to consider the answer for yourself. So, our case to consider, we have a 21-year-old boy. He's brought to the emergency department by his college roommates after suddenly becoming lethargic and unresponsive. Earlier in the day, he had a fever, irritability, and developed purpuric rashes on his trunk and extremities. On arrival, he's febrile to 39.8, hypotensive to 68 over 38, tachycardic to 160, and poorly perfused with delayed capillary refill and cool extremities. He's minimally responsive to verbal stimuli. His past medical history is notable for a bout of meningitis at age 10 that led to hospitalization for 7 days. He was up to date on vaccinations until age 10. On physical exam, he has a non-blanching purpuric rash and signs of meningeal irritation, so he's got knuckle rigidity and photophobia. IV fluids are given at 30 cc's per kg per hour with no appreciable increase in his blood pressure. IV norepi is given at a dose of 2 to 5 micrograms per minute, but the blood pressure only rises to 75 over 42. Here are his labs on admission. His white blood cell count is 18,000. He's got a left shift. Platelets are 38,000. Serum sodium is 130. The glucose is 55. Cortisol is pending. The CT head shows no mass effect, and blood cultures are pending. So take a second, try to just consider what you think is going on in this case, and then we'll move forward. So my first question for you to consider is, what is the sepsis 5-hour bundle? So you can pause the screen, take a second to consider. So the sepsis 5-hour bundle includes 5 things we should order or do within the first hour of suspected sepsis. So that would be getting blood cultures, getting blood lactate, starting empiric antibiotics, starting IV fluids at 30 cc's per kg per hour. And then if their mean arterial pressure is less than 65, we're going to start pressors. And the pressor of choice in sepsis is norepinephrine. A lot of good data on norepinephrine. The reason we usually prefer norepinephrine over things like maybe epinephrine as a pressor is, let's think about the mechanism of action, right? Norepi really works on alpha 1, alpha 2, and beta 1. Okay, very little bit on beta 2, but really the alphas are the big player here. When we think about epinephrine, it's really going to be kind of just broad, and it's going to be beta 1, beta 2, alpha 1, alpha 2. Now, everyone knows beta 2 in the lungs. When I activate beta 2 in the lungs, we cause bronchodilation. But what a lot of people don't remember is that beta 2 receptors also sit on my vasculature. And when beta 2 gets activated on the vasculature, it causes vasodilation. So let's think about the pathophysiology of sepsis here, right? The underlying pathophysiology of sepsis, the reason the patient's in shock is because of these leaky vessels, right? This cytokine storm from this overwhelming infection that is causing leaky vessels, and then there's a lack of blood flow to tissues. Thus, there's hypoperfusion. The lactate level increases, right? That's why we get lactate in these patients right away, so we can trend the lactate. Is it going in the right direction? Is it going back down? Are we now able to perfuse our patient? So if norepinephrine isn't really touching the beta receptors or the beta 2 receptor, but it is touching the alpha 1, right? Really good. Alpha 1 causes vasoconstriction. That's what we want. Epinephrine, on the other hand, is going to have some activity at the beta 2 receptors, and that's going to cause dilation. Now, again, it will work at the alpha 1 receptors too, but we're kind of like fighting ourselves here. If we're activating alpha 1 and beta 2 at the same time, it's not really doing us the best. And we've seen in a lot of clinical trials, norepinephrine is demonstrated to be the best pressor we've got for sepsis at the moment. So that's the sepsis 5-hour bundle. There's everything I said right here. The IV lactated ringers is preferred over 0.9% normal saline. This is in the guidelines for the Surviving Sepsis campaign. We're going to talk about why in a second. But everything I said, blood cultures, lactate, empiric antibiotics, our fluids, and then we start the norepinephrine if the MAP is less than 65. Remember, to calculate our MAP, we take 2/3 times the diastolic blood pressure plus 1/3 over or times the systolic blood pressure. If that number there is less than 65, then we should start pressors. Okay, we go fluids, pressors, and then if the pressors aren't fully cutting it, we can potentially consider giving IV albumin. Okay, so there's some data on that. That's a story for another day. But really, albumin will act to draw fluid into the intravascular system. Um, there was a brand new trial at the end of 2024, early 2025, that showed, it's called the ADAPT sepsis trial. It showed using procalcitonin to trend procalcitonin to let us know when to stop antibiotics. So this reduced antibiotic exposure in the critically ill patients with suspected sepsis and really provided great antimicrobial stewardship. CRP guided protocols didn't usually show the same kind of significance in level, right? So basically, another what this trial is suggesting, and hasn't been formally placed into guidelines yet, but a lot of doctors, especially I saw at like my children's hospital rotation, was that physicians would order the Procal and would trend it, right? The ADAPT sepsis trial showed that when the Procal drops by 80% or it's less than 0.25, that's a good marker that we can stop the antibiotics, okay? It's just another marker we can get to trend basically how is the patient doing, right? If you're taking step maybe in a year or two, this would be a fair game question. As of now, like if you're taking a step in the near future, they probably won't ask you about Procal because it's too early. So again, Procal can help us reduce the length of antibiotics we're using in sepsis. So now my question for you is, why does a surviving sepsis campaign say we should use lactated ringers over 0.9% normal saline? Both are isotonic solutions, right? And in a pinch, right, normal saline can absolutely be used. But why, if we have both available to us, why are they suggesting lactated ringers over normal saline? So take a second. So lactated ringers is a balanced crystalloid and it more closely mimics like our plasma composition. So the way I think about it is 0.9% normal saline has a sodium chloride load of 154 millimoles. That means we're getting 154 millimoles of sodium, 154 millimoles of chloride. Lactated ringers, like the sodium millimole load is usually like it's like 109. When I look at my normal sodium load in my body, what's the normal sodium in the extracellular space? Well, it's about like 135 to 145. So let's just call it 140. So that's pretty close to 154. You know, it's not too far off. But then let's think about what our normal chloride load is in the extracellular space. That's like 100, right? So we're giving them way, way, way more chloride than our body is used to. When I give a patient IV fluids via 0.9% normal saline, especially at 30 cc's per kg per hour. So when I give the patient that much normal saline, we're giving them a huge chloride bolus, right? Is chloride negative or positively charged? It's negatively charged, right? So it's an anion. What's the other really, really important anion in our body? So that's going to be bicarb, right? If you remember from your physiology M1 year, bicarb and chloride are linked, right? They're linked in the pendrin exchangers. They're linked in our kidney tubulars too. So if my body senses an excess chloride load, the negatively charged, it's going to do what it has to do, and it's going to remove the reabsorption of bicarb, okay? Because we need to be at electrical neutrality. So if chloride is increasing, bicarb will decrease, and usually vice versa, okay? So in this case, right, maybe you've seen on an Anki card and just blindly memorize, if I give the patient too much 0.9% normal saline, we're increasing the chloride load by a huge amount, we're decreasing the bicarb, and it can lead to hyperchloremic metabolic acidosis. Okay, we're losing bicarb, puts us into an acidotic state with elevated chloride. That would be a non-anion gap, because remember, my anion gap is sodium minus chloride plus bicarb. We're increasing the amount of chloride, not some random anion that we can't measure. Okay, so in a patient with sepsis, they're already in an acidotic state, right? Their lactate is usually high. So why would I put them in a further lactated or a further acidotic state, right? The other thing is when we give a really high chloride bolus, that can also injure the kidneys and cause renal vasoconstriction, and that would further reduce the amount of blood flow to the kidneys, okay, which would be even more catastrophic. So now I know what you're thinking is, wait, why would we give them lactated ringers if their lactate is already elevated? Well, that's where kind of like you need to understand some more physiology here. Is the lactate in lactated ringers isn't necessarily the same as like the lactate running through our bodies. It's sodium lactate. Okay, that's the lactate in sodium or in lactated ringers. When I give the patient that bolus, it makes its way to the liver and it gets converted into bicarb. And so that lactated ringers that we gave the patient actually will get converted to bicarb and will actually serve as a buffer for the acidotic state. Okay, so that actually will end up helping us in the long run. So lactated ringers is usually like the go-to solution for a lot. Like if you're asked a question on an exam, like lactated ringers is a great option for most things. It's a great option for burn patients. It's a great option for really a lot of different conditions we're going to see. If the patient has like a few different things where I wouldn't consider lactated ringers. One of them is if the patient has liver damage, right? Remember, I told you lactated ringers get broken down into bicarb in the liver. If they have liver damage, then that's bad. Now the lactated ringers can build up. Another situation would be if the patient has like recent brain surgery or brain trauma, lactated ringers is hypotonic. And so because it's hypotonic, it's going to cause a movement of fluid, right? So think about if it's hypotonic, where's the fluid going to move? Is it going to move in or out of the cells? So if I give them a hypotonic solution, it's going to move into the cells, right? In a patient who has had recent neurosurgery or brain trauma, that brain parenchyma is already kind of like fragile. So we're asking here for cerebral edema, right? If I give them too much lactated ringers, okay? Another place where we could potentially use like normal saline over lactated ringers is a patient who has been vomiting and has hypochloremic, hypokalemic metabolic alkalosis, right? So giving them normal saline would be great to increase the chloride load and put us back into a normal pH system, right? So it's all things to think about. The 2021 American College of Emergency Physicians Surviving Sepsis Campaign Guidelines both recommend lactated ringers over normal saline for the reasons I just recommended. Okay. Um, so now thinking about our case, what is the pathophysiology of this patient's disease? So what's the underlying problem going on in this patient? So in this patient, right, this is classic Waterhouse Friedrichsen syndrome, secondary to Neisseria meningitis, right? This is due to the weird endotoxin found in Neisseria meningitis, okay? This endotoxin is going to trigger coagulopathy and DIC. If you need a refresher on DIC, please watch my liver versus DIC video. It's a short, like 5-minute lecture where I kind of go over that. This can lead to hemorrhagic necrosis of the adrenal glands and lead to an acute primary adrenal insufficiency, which we're going to talk about soon. This can lead to shock, a purpuric rash secondary to my DIC and my cytokine storm, causing a lack of platelets, right? A lack of coagulation factors, bleeding into the skin, right? We have electrolyte derangements, we have hypoglycemia. So that kind of whole clinical picture we just saw. So basically what I'm trying to get at is if you see a patient on a clinical vignette or a patient in real life who has classic meningitis symptoms, right? They have this purpuric rash, right? Their blood pressure is plummeting. They're hypoglycemic. They're not responding to fluids. You should think about Neisseria meningitis causing adrenal gland destruction, right? We should absolutely consider Waterhouse-Friedrichsen syndrome. A little bit more about our endotoxin here. The Neisseria lipo-oligosaccharide, it lacks the O antigen, okay? So most gram-negatives have a lipopolysaccharide. Neisseria has a lipo-oligosaccharide, okay? It lacks this O antigen. It still has that lipid A, which is one of the core oligosaccharide portions, and the lipid A is responsible for this endotoxic effects. Basically, our body is not used to this LOS, right? It's not used to the LPS either, but this LOS is just so abnormal that it just causes a massive cytokine storm, okay? The cytokine storm is going to cause a vascular collapse. It can trigger the destruction of the adrenal glands, and now our patient is really down bad, right? They have meningitis, they have bacteremia, they have DIC, they have adrenal gland destruction, okay? This lipo-oligosaccharide also can potentially be used for the meningitis or the Neisseria meningitis to avoid immune detection as well. All right, moving on. So I want you to think about what is the standard vaccination sequence for Neisseria meningitis. So they're going to get 2 doses of the men ACYW at 11 to 12 years, and then a booster at 16. And then the men B, right? Everyone has to get the men B before going to college. You usually get it between 16 to 23, usually 2 doses. If it's a high risk individual, they can get 3 doses. So remember, like in asplenia, like maybe we have a patient who had trauma and had to get their spleen out, or they have sickle cell and they have functional asplenia. We're really concerned about our encapsulated bacteria. What would be my encapsulated bacteria that I'm worried about? So those would be strep pneumo, Haemophilus, Neisseria species, and then Salmonella. Okay. We have vaccines for Haemophilus, strep pneumo, and Neisseria meningitis. The Salmonella is hit or miss, right? There are some for some of the lesser strains, but they're not really readily available in America. So really what we consider, and for your answers on board exams, would be we would need to vaccinate against strep pneumo, Haemophilus, Neisseria meningitis if we have a patient with sickle cell or they don't have a spleen, right, for some reason. All right, moving forward, what is a standard of care empiric antibiotic regimen for presumed bacterial meningitis, right? So patient presents, we have a strong suspicion of Neisseria meningitis. They have a positive Kernig sign, right, where we're extending their knee. It causes meningeal irritation. We have the positive Brudzinski sign. So we place the back of their head. We move their back of their head, and that causes meningeal irritation. They have photophobia. They have phonophobia. They have a high fever, right? Everything's kind of leading us towards meningitis. What should we start? So classically, especially if you're getting ready for step 2, you probably know this like the back of your hand. We're going to start Vanco. We're going to start a 3rd generation cephalosporin, so like ceftriaxone. If they are less than a month or they're older than 50 years or immunocompromised, we're going to add ampicillin. If we have a clinical suspicion of HSV encephalitis, we're going to add acyclovir. Okay, I didn't add that on the slide, but you can consider that. Right, HSV encephalitis. So encephalitis versus meningitis. In encephalitis, you usually have altered mental status and confusion, and meningitis, you usually don't. HSV encephalitis is usually a little bit more subacute versus an acute presentation like we saw in this patient. HSV encephalitis will classically impact the temporal lobes, right? That's because of like the way HSV translocates like back through our like dorsal root or the dorsal roots back up through the brainstem. It classically can get to the temporal lobes, and they're still trying to figure out why. They're still trying to figure out the mechanism of why, so they can never ask you that on a board exam because they don't fully understand why. They know it has something to do with wherever HSV sits in our CNS system. It gives them a pretty good path to the temporal lobes, but you'll see either unilateral or bilateral temporal lobe lesions. If we did a CT or potentially like an MRI, would probably show it better. If I did a lumbar puncture, we're going to see likely a bloody tap, right? We're going to see red blood cells or xanthochromia if we did that, right? That's all keying me in on a patient having HSV encephalitis, especially if they have a past history of having HSV, right? They have a history of the cold sores, or potentially like that, genital lesions. I want you to consider, just because I talked about it, right? If we have a patient, we do a CSF puncture and they have a bloody tap, what are like the 3 big things I should consider? One of them is obviously HSV encephalitis, right? HSV is going to get to the temporal lobes. It's going to cause a huge inflammatory response. We're going to cause hemorrhagic destruction of these vessels, and we're then going to bleed into the CSF, right? So that's one of them. What's another one? The other one would be subarachnoid hemorrhage, right? Obviously, if we're having hemorrhage of my subarachnoid vessels, we're easily going to get blood into the CSF fluid, right? The last one would be like an actual bloody tap. When I stick my needle into the CSF space, right, sometimes blood can get in there. It doesn't matter how good of a physician you are, right? Every now and then, right, it can happen. It's just part of the procedure. The way we kind of remedy this is we will take the samples and we will wash them down. Okay, so or we'll like centrifuge them down. A patient who has a purely bloody tap due to procedural problems, we centrifuge it down, down, and down. We're going to lose that blood, okay? Because it's not true blood, right? It's not like an actual bleeding process in the CSF. It was we stuck the needle in, it caused a little bit of bleeding, and it's done, okay? If the patient has HSV encephalitis or subarachnoid hemorrhage, that's an ongoing process. doesn't matter how many times I centrifuge that down, the blood is going to stay in my centrifuge, right? It's going to stay in my CSF sample. Okay, so that's one way you can think about it. The other thing I wanted to say about empiric antibiotic regimen is dexamethasone has proven effective in strep pneumo and even in H. influenza in adults. It has proved effective in improving outcomes, improving neurological outcomes, preventing hearing loss. So a lot of the times we will start dexamethasone if we suspect bacterial or bacterial meningitis, and then if it's not strep pneumo or not H. influenza, we'll pull off the dexamethasone. Okay. One thing I want to consider is the fails mnemonic. These come from the IDSA, the Infectious Disease Society of America, 2004 guidelines, and they're still used today. So that's how effective they are. These are indications for getting a CT before you do a lumbar puncture. So the reason I would want to get a CT before a lumbar puncture is if I suspect there's some sort of mass in the brain, and if I stick a needle into their CSF space and I pull off fluid, it's reducing the pressure here. I've got increased pressure here, decreased pressure now in my spinal cord, and it's going to draw things back, right? So it's like removing, I think about it like Jenga, right? If I pull off one of the bottom pegs of my Jenga block, the whole thing's going to tumble down, right? Especially if it's really top heavy, okay? So in this case, what I want to do is I would get a CT scan of the head before a lumbar puncture, make sure there's no mass or no lesions or anything, and then I know it's safe to do a lumbar puncture because we'll reduce the risk of having a brain herniation. So the fails mnemonic is exactly kind of what it sounds like, right? The F stands for focal neurological deficits. So do they have focal neurological deficits? If yes, get a CT scan. Do they have altered mental status? If yes, get a CT scan. Are they immunocompromised, or do they have things like increased ICP, like papilledema? If yes, get a CT scan. Do they have a lesion, or do they have a known history of brain cancer? If yes, get a CT scan, right? Do they have a seizure? Did they present with a seizure, or have they had a seizure within 1 week? If yes, get a CT scan. Our patient kind of hit a lot of these, or at least some of them, right? And that's why I gave you, if we go all the way back to our exam or to our vignette, I gave you, we did a CT head that showed no mass. So now it's safe to do a lumbar puncture. All right. I think that's what I wanted to say on that. All right. So how can we differentiate bacterial meningitis from viral meningitis, right? We do a CSF sample. What's going to tell me it's more bacterial versus more viral? So in this case, right, we can think about the onset, right? Bacterial meningitis is usually a little bit more acute. Viral is a little bit more subacute. The fever is usually pretty high in bacterial, maybe a little less in viral. The white blood cell count is going to be pretty high in bacterial, and it's going to be neutrophilic pleocytosis, whereas in viral, it's usually a little bit more mild and it's lymphocytic pleocytosis. The CSF protein is usually pretty elevated in bacterial, maybe less so in viral. The CSF glucose is really low in bacterial. That's because the bacteria eat up the glucose, and it's usually pretty normal in viral. A trick you can do is you can take the patient's CSF glucose, you can divide it by their serum glucose, and if that value is less than 40%, that also keys me in that it might be bacterial. You have to be careful because it could also be fungal or TB, because both TB and fungi can eat up the bacteria too, so we have to do a little bit more. It's not a fully specific exam, but if it's less than 40%, we can kind of be like, it's probably not viral. And then we can do a gram stain. Remember, the gram stain might take a bit though, so it's not going to be like we're going to have to wait until we get the definitive what's on the gram stain, so then we can dictate antibiotics further. All right. So what is the standard of care antibiotic regimen for Neisseria meningitidis? What prophylactic antibiotic or antibiotics should be given to close contacts of this patient? So if the patient has confirmed Neisseria meningitis, we're going to treat with IV ceftriaxone or cefotaxime, and we can discontinue the dexamethasone, right? Because Neisseria meningitis has never proven, the dexamethasone has not proven effective in Neisseria meningitis meningitis, okay? If the patient has been in close contact within 7 days to individuals, We usually like to give them rifampin, okay? Or we can give them ceftriaxone if the patient is pregnant, or ciprofloxacin if they're adults, right? If they're kids, we don't want to give ciprofloxacin. That can damage the collagen, right? Also, if it's an older adult, we probably don't want to give ciprofloxacin. That can cause neurological dysfunction, and it can damage their collagen as well. So all things to consider. Really, rifampin is going to be our go-to. They love asking about this, but I've seen a couple questions where rifampin's not listed as an answer option, so you have to know ceftriaxone and ciprofloxacin too. Okay. How can we differentiate primary from secondary adrenal insufficiency? And while you're thinking about that, I wanted to go back to the STEM and also ask you, why is this patient's serum sodium low, right? 130 is low. If you watch my hyponatremia lecture, you probably have a good idea why, right? If you didn't watch my hyponatremia lecture, when you're done with this video, go watch the hyponatremia lecture, and you'll be able to give me a beautiful explanation of why it's low. So we'll start with why it's low. Cortisol normally inhibits antidiuretic hormone. When I have a patient with adrenal insufficiency, doesn't matter if it's primary or secondary, in both cases, cortisol is going to be low. And when cortisol is low, it allows ADH to run free. ADH is going to cause dilution of my serum sodium, because ADH causes translocation of the aquaporins. We cause reabsorption of all the water. A lot of my solutes stay into the tubular system, and we end up diluting out my serum sodium, okay? Watch my explanation, because I explain how primary adrenal insufficiency can lead to hypovolemic hyponatremia, and secondary adrenal insufficiency can actually lead to euvolemic hyponatremia. It's a small difference, but the physiology makes a lot of sense. I explain it fully in the hyponatremia lecture. So now let's think about how can we differentiate primary from secondary adrenal insufficiency. So primary adrenal insufficiency is going to be due to destruction of the adrenal gland itself, right? The most common cause is going to be autoimmune adrenalitis. So that's antibodies towards 21-hydroxylase. Other causes, like the most common cause worldwide, is TB. And then we have things here like Waterhouse Friedrichsen syndrome too. These are all classics. With regards to primary adrenal insufficiency, if I lose aldosterone, or if I lose cortisol, right, and aldosterone, we're going to have different problems in secondary adrenal insufficiency, which I'll talk about in a second. So I think we should take a second and just think about the adrenal gland and think about like its composition. So what are my layers of the adrenal gland from outer to inner? So the outer portion is the glomerulosa. That's going to secrete aldosterone. Then we move more in, and that's the fasciculata. That's the glucocorticoids. Move in even more. That's the reticularis. That's androgens. Move in even more. That's my medulla. That's norepinephrine and epinephrine, right? So in primary adrenal insufficiency, we damage the entire adrenal gland, right? So the two big things I really care about in terms of like acute adrenal failure or like adrenal crisis are going to be cortisol and aldosterone, right? The glomerulosa and the fasciculata. Cortisol has a really important role, like so many roles. I could do a whole entire lecture on cortisol, but in terms of the presentation of acute adrenal insufficiency, cortisol stimulates, it helps sensitize the alpha-1 receptors on my vascular endothelium, right? What do we talk about? The vascular endothelium, norepinephrine likes binding to alpha-1 and causing vasoconstriction, okay? If we don't have that sensitization, the vessels aren't able to respond to norepinephrine as appropriately. Cortisol also will cause insulin resistance, right? So if my cortisol is low, we could be hypoglycemic, right? Because we lose that underlying insulin resistance, okay? Cortisol also inhibits eosinophils. So sometimes if the patient has long-going adrenal insufficiency, their eosinophils could be elevated, okay? We also can think about, okay, what happens when aldosterone is low, right? What does aldosterone do? Aldosterone keeps sodium in water. It pumps out potassium and H+. So we've lost that. We're losing the reabsorption of sodium in water, so my blood pressure plummets even more. We're losing the release, the excretion of potassium and H+, so we could develop hyperkalemia, and we could also develop metabolic acidosis. It's classically a non-anion gap metabolic acidosis. Kind of like the last thing I'll say here is like the overall presentation, like the patient will have nausea, fatigue, weakness, vomiting, right? They're going to be really sick. If this is long-going primary adrenal insufficiency and we have destruction of these adrenal glands over time, it lessens the negative feedback to the anterior pituitary and the hypothalamus. So my hypothalamus secretes CRH that tells my anterior pituitary make ACTH. The ACTH goes down to the adrenal gland and tells us, hey, make cortisol. Okay. If we lose that, the ACTH is going to be sky freaking high, right? ACTH is made from the POMC gene. Other things made from the POMC gene are things like alpha MSH and beta endorphins, okay? So when alpha MSH, alpha melanocyte stimulating hormone, and ACTH, adrenal corticotrophic hormone, when those are elevated, both of them actually can cause this hyperpigmentation, okay? MSH is probably the one you're always taught because it's melanocyte stimulating hormone. If you look at the literature, ACTH can also cause hyperpigmentation too, because they kind of share, obviously, like some of the same backbone. So with regards to this, right, the patient could be hyperpigmented. Now, you're not going to look for a patient who's like completely bronze, like they just went tanning, right? But you're going to want to look at like the back of the knuckles. You're going to want to look at like mucosal surfaces, like inside of their mouth, their gums, and that can kind of key you in, right? If the patient has no hyperpigmentation, it doesn't necessarily mean that it's not primary adrenal insufficiency. It could be primary adrenal insufficiency, but it's just too much of an acute presentation. So like in our case, on this one, the patient had acute adrenal crisis, right? Acute hemorrhagic necrosis. He's not going to be hyperpigmented because we need that ACTH and MSH to be up for like a while to actually cause this hyperpigmentation. With regards to secondary adrenal insufficiency, this is damage to the hypothalamus or the pituitary itself. So the adrenal glands are still functioning. They're just not getting the signal to release cortisol, okay? So in this case, right, the skin pigmentation would not be evident because ACTH and MSH are still being, they're not being made in this case, right? Because there's damage to the antipituitary or the hypothalamus, right? So if I lose that, I'm not going to get that hyperpigmentation. The other thing that's really important is that aldosterone is still going to be active here. Aldosterone is regulated by the renin-angiotensin system, and the renin-angiotensin system is being stimulated from the JG cells, right? JG cells sense low blood sodium chloride, low blood volume, high sympathetic activation. They release renin. They go, the liver will make angiotensinogen. Angiotensinogen will get converted will convert Ang1 to Ang2. Ang2, that happens, the Ang1 to Ang2 will happen in the lungs, right? That Ang2 will then go down to the adrenal glands and cause the release of aldosterone, right? That whole system is totally intact, right? So aldosterone will be intact. We'll get the saving of sodium and water. We'll get the excretion of potassium and H+, and all will be good, okay? So that's why these patients are usually euvolemic, because we keep aldosterone. We shouldn't see hyperkalemia, and we shouldn't see metabolic acidosis, right? So again, the renin-angiotensin system, we release renin. We get the conversion of Ang1 to Ang2 via the ACE enzyme, classically in the lungs, right? Ang2 can then go down to the adrenal glands and stimulate aldosterone, okay? We're going to talk about the response to ACTH in a second here, but that's kind of how I think about the difference between primary and secondary adrenal insufficiency. A classic example of like secondary adrenal insufficiency is a patient who has an autoimmune condition. They've been on a chronic steroid for a long time. They run out of their steroid or they forget about it. They get sick. They get stressed. They don't have that ACTH to respond. So they've been on the steroid for so long. It tells your anteropituitary, hey, you don't need to make ACTH anymore because we're getting all this exogenous steroids. The minute we take their steroids off, their anteropituitary is not responding appropriately. So the next time they get stressed, if their pituitary and their adrenal glands have not woken up, right, we're not able to release enough of the ACTH. Our adrenal glands not able to respond with enough cortisol, and we can go into an adrenal crisis. All right. So the next thing I want to ask is, when would you choose to treat adrenal insufficiency with dexamethasone versus hydrocortisone? So hydrocortisone has both mineralocorticoid and glucocorticoid properties, right? That makes it great, right? If it's primary adrenal insufficiency, we're missing both. Let's give him hydrocortisone, right? It's short acting and it will allow us to do the ACTH test later, right? If it's dexamethasone is pretty much just a glucocorticoid. It does not have mineralocorticoid properties. This would be a great option if we're going to try to do the ACTH test like very soon, because it really does not interfere with the cortisol assay. In adrenal, like acute adrenal insufficiency, though, we want to give hydrocortisone most likely because it's got both mineralocorticoid and glucocorticoid properties, right? We also have a drug called fludrocortisone. Fludrocortisone is synthetic aldosterone, right? To think about briefly, the morning cortisol test, right? If we want to test, is this primary versus secondary adrenal insufficiency? We're going to do a lab draw between 6 to 10 a.m. of cortisol, right? The key thing you want to remember about like endocrine testing is if we suspect the hormone is low, we should test it when it should be high. If we suspect the hormone is high, we should test it when it's low, right? When does cortisol peak? Cortisol peaks early in the morning, right? So if I suspect the cortisol is low, let's test it early in the morning. That's the same reasoning why when Cushing disease, you do your midnight salivary cortisol test, right? Cortisol should be very low at midnight when we're trying to go to bed or when we're sleeping, right? So we should test it when it's low. And if it's inappropriately high, that tells me, hey, we're making cortisol from places it shouldn't be made, or we're making too much cortisol. So in this case, right, if cortisol should be high at 8 a.m., let's say, and it's actually low, that's abnormal, okay? So to interpret it, if the cortisol is greater than 18, it rules out adrenal insufficiency. If it's less than 3, we pretty much have our diagnosis of adrenal insufficiency. If it's between 3 and 17, well, now it's indeterminate, and we have to go to the ACTH stimulation test, okay? There are limitations, and that's beyond what I'm going to talk about today. For the cosentropin stimulation test, we have our baseline. So now we want to figure out, is this primary or secondary or tertiary adrenal insufficiency. So what we do is we give 250 micrograms of IV or intramuscular cosentropin, which is just ACTH, and we're going to measure the cortisol at 0, 30, and 60 minutes. A normal response would be the cortisol would rise greater than 18 to 20, okay? So that would be a normal response, okay? We can just further break it down by looking at this table I made. So in primary adrenal insufficiency, the ACTH levels are sky freaking high because we damage the adrenal glands. There's a lack of negative feedback. ACTH is really high. After I give the cosentropin, there's low rise to the ACTH. That's because the adrenal glands are defeated, right? They've been destroyed. It doesn't matter how much ACTH I give them, it's not going to do anything, right? So there's not going to be a rise. In secondary adrenal insufficiency, the ACTH is usually low or it's potentially normal. And in this case, the cortisol after the cosentropin will be normal or it will have a delayed rise, okay? That's because we're giving them the hormone they're missing. It just really depends on how long this secondary adrenal insufficiency has been going on, because their adrenal glands might be atrophied, okay? So in chronic secondary adrenal insufficiency, again, the ACTH is lower normal. In this case, we're probably not going to see a rise. That's because their adrenal glands have atrophied, right? Because it's adrenal corticotrophic hormone, right? So if I'm losing that corticotrophic capability, that trophic capability, over time, my adrenal glands are going to die, right? And they're not going to be able to respond to the hormone they're missing. So again, in primary adrenal insufficiency, we have an increased amount of ACTH, but the adrenal glands are destroyed. It doesn't matter how much ACTH I give them, there's not going to be a rise in cortisol, or there's not going to be an appreciable rise. In early secondary adrenal insufficiency, they're missing this hormone, the ACTH. Their adrenal glands are totally normal. If I give them the hormone they're missing, we should see a response. If it's chronic secondary adrenal insufficiency, well, then they've been missing the anterior pituitary hormone for way too long. There's no trophic effect on the adrenal glands, so their adrenal glands start to atrophy. It doesn't matter if I give them the hormone, their adrenal glands aren't going to respond. All right. After the patient is stabilized, we further find out about his history that I gave you in the vignette, that this is his second bout of meningitis caused by Neisseria. What test would you like to order next, right? He's stabilized. We find out he's had Neisseria meningitis twice now. What does that key you in on? So whenever I think about a patient who's had more than one bout of Neisseria meningitis, I always think about terminal complement deficiency, okay? My terminal complement is my C5b through C9. They form this MAC complex. The MAC complex forms holes in a lot of our bacteria and is super duper duper important to get rid of Neisseria meningitis. So I would suspect that this patient might have a terminal complement deficiency. And what we would do is we do the total complement activity. We can evaluate their terminal complement. And if it's abnormal, we can make the diagnosis of terminal complement deficiency, right? So a really key thing I want you to key in on is if you see a patient who's had meningitis more than twice in their life or like more than once, we should consider potentially getting the terminal complement protein, especially if it's been Neisseria species more than once. Okay, that's a big red flag. All right. Okay, so that was a lot of information. We covered sepsis, we covered Waterhouse Friedrichsen syndrome, we covered Neisseria, we covered treatment for meningitis, we covered how to differentiate bacterial versus viral meningitis, we covered primary versus secondary adrenal insufficiency. We even talked about ADH again in our RAS system that I talked about in hyponatremia. I hope this helped. If you have questions, you can email me. Feel free to share the video. Let me know what else you want me to cover.